Welcome to another episode from the Veterinary Medicine Digest. Transfusions are undeniably a critical and potentially life-saving procedure in veterinary medicine, serving as a vital therapeutic option for both dogs and cats suffering from anemia or coagulopathies. However, administering blood products is far from a benign process, carrying definite risks of serious adverse reactions if not approached with meticulous care and comprehensive knowledge of blood incompatibility. As the field of veterinary transfusion medicine continues to grow in complexity and availability, mastering the intricacies of blood typing, compatibility testing, and managing potential reactions has become essential for ensuring safe and effective treatment for our small animal companions. Today, we delve deep into this essential area of clinical pathology, examining the protocols for dogs and focusing particularly on the unique and high-stakes world of feline transfusion, drawing heavily on recent consensus guidelines and research to provide a truly insightful look into best practices. The foundation of transfusion safety, donor screening and preparation. The journey of a safe transfusion begins long before the blood ever reaches the recipient patient. It starts with rigorous screening of the blood donor and careful management of the donated product. The primary goals of laboratory testing in donor screening are twofold. First, to protect the well-being and health of the donor during the donation process, and second, to drastically reduce the risk of transmitting infectious diseases or blood-borne pathogens to the recipient. Standard screening protocols recommend obtaining a complete history and performing a thorough physical examination of the donor animal. This initial evaluation is supported by clinicopathologic screening, including a complete blood count, a serum chemistry panel, urinalysis, and a fecal examination. Crucially, a packed cell volume measurement must be determined immediately prior to every single collection to ensure the donor is suitable and healthy enough to proceed. Beyond general health markers, canine and feline donors must undergo rigorous testing for infectious agents, following guidelines set forth by professional bodies. The sources highlight the importance of utilizing advanced screening methods, specifically recommending the use of polymerase chain reaction testing in addition to traditional serological tests for screening for selected transfusion-transmitted infections. This combined approach, polymerase chain reaction plus serology, helps reduce the possibility of transmitting infections, but also helps identify seropositive donors who may not have an active infection. For specific pathogens such as Mycoplasma haemophilus, Mycoplasma haemominutum, and Mycoplasma turacensis in cats, polymerase chain reaction is often the only viable test since readily available serologic assays are lacking, and microscopic evaluation of blood smears offers poor sensitivity. Similarly, polymerase chain reaction testing is the only way to identify feline leukemia virus-infected cats that are provirus positive but antigen serological negative. For cats, screening should cover core infectious agents such as hemotropic mycoplasmas, Bartonella species, feline leukemia virus, and feline immunodeficiency virus. Ideally, donors should test negative by polymerase chain reaction for these agents, especially in endemic areas. Once blood is collected, the safety precautions shift to the product itself. Before any unit is administered, practitioners are strongly advised to check the blood product for evidence of hemolysis. Hemolysis, or the rupture of red blood cells, can occur due to various factors including issues with donor cells, the product's age, processing errors, storage conditions, or bacterial contamination. The infusion of free hemoglobin released during hemolysis is not benign. It has been implicated in tissue damage, specifically renal proximal tubule damage. While there are no official veterinary standards comparable to human medicine, where hemolysis must be under 1%, the general consensus suggests that any red blood cell unit exceeding 1% hemolysis should not be used, and this assessment should ideally be done by measuring free hemoglobin rather than relying solely on unreliable visual inspection. Visual inspection for color changes is also recommended. For instance, a unit that darkens to black during storage suggests contamination and warrants further inspection and testing. Canine blood typing. The dog erythrocyte antigen system. Before delving into the complexities of feline blood groups, a brief overview of the canine system is instructive, as it provides a crucial contrast, particularly regarding the presence of naturally occurring antibodies. In dogs, the traditional nomenclature centers around the dog erythrocyte antigen system. Dog erythrocyte antigen 1, the immunogenic star. Of all the initial blood types identified within the dog erythrocyte antigen system, dog erythrocyte antigen 1 is considered the most critical and highly immunogenic antigen. If a dog erythrocyte antigen 1 negative dog is transfused with dog erythrocyte antigen 1 positive blood, the immune system will be sensitized, potentially leading to a massive alloantibody response and a severe acute hemolytic transfusion reaction upon subsequent exposure. Crucially, dogs generally lack naturally occurring alloantibodies against the dog erythrocyte antigen 1 antigen. This biological reality means that a dog erythrocyte antigen 1 mismatched transfusion in a dog that has never been transfused before, a transfusion-naive patient, typically does not result in an immediate acute hemolytic transfusion reaction. This lack of preformed antibodies has historically led to the common, though increasingly scrutinized, practice of deeming the first canine transfusion safe, without extensive compatibility testing. However, once sensitized, the second transfusion of incompatible blood, even several years later, can be fatal. Newer antigen discoveries. While dog erythrocyte antigen 1 remains the primary focus of compatibility testing in dogs, researchers have continuously expanded the recognized blood group landscape. Other classic dog erythrocyte antigens, specifically dog erythrocyte antigen 3, 5, and 7, have been linked to alloantibody formation, though they typically cause delayed transfusion reactions rather than immediate, life-threatening acute hemolytic reactions. More recently, antigens outside of the dog erythrocyte antigen system have been documented, including the DAL antigen and the Chi system, Chi1 and Chi2. The DAL antigen is particularly noteworthy because while most dogs are DAL positive, a significantly higher percentage of certain breeds, specifically Dalmatians, Doberman Pinschers, and Shih Tzus, are DAL negative. This DAL negative status increases the risk of sensitization and subsequent hemolytic reactions if they inadvertently receive DAL positive blood. The discovery of these non-dog erythrocyte antigen systems underscores the reality that even dog erythrocyte antigen 1 matching alone does not guarantee perfect compatibility, and dogs can still develop cross-match incompatibilities due to exposure to these untested antigens. The feline imperative, blood typing and incompatibility. In stark contrast to dogs, feline transfusion medicine is characterized by an immediate and critical risk due to the widespread presence of strong, naturally occurring alloantibodies. The consequences of a mismatched transfusion in a cat are often swift and fatal. The feline AB blood group system. The predominant and most well-defined system in cats is the AB blood group system. This system categorizes cats into three primary phenotypes: type A, type B, and the rare type AB. The risk inherent in this system is driven by alloantibodies that are naturally present in the cat circulation, meaning they exist even if the cat has never received a transfusion. 1. Type A cats. These cats possess the N-glycolylneuramic acid allantigen. The majority of type A cats possess anti-B alloantibodies, though these antibodies are usually present in low concentrations and are generally considered weak. If a type A cat receives type B blood, the reaction tends to be delayed and less severe, usually resulting in shortened red blood cell survival rather than an immediate acute hemolytic crisis. 2. Type B cats. These cats carry the N-acetylneuramic acid allantigen. All type B cats possess strong, high-titer red anti-A alloantibodies, which are primarily of the immunoglobulin M class, giving them powerful agglutinating and hemolyzing capabilities. If a type B cat receives even a small volume, as little as 1 milliliter, of type A blood, these preformed, potent anti-A antibodies will immediately target and rapidly destroy the transfused red blood cells, leading to a life-threatening, acute hemolytic transfusion reaction. The destruction of transfused red blood cells in a type B cat receiving type A blood is extremely fast, typically resulting in total red blood cell clearance within hours. 3. Type AB cats. This phenotype is rare, possessing both N-glycolylneuramic acid and N-acetylneuramic acid allantigens. Crucially, type AB cats never possess alloantibodies against either type A or type B antigens. If type AB blood is unavailable for a type AB recipient, type A blood, or ideally, type A packed red blood cells, may be administered. Because of these powerful, naturally occurring antibodies in type B cats, pre-transfusion blood typing is not merely advised, it is deemed absolutely mandatory for every single feline transfusion to avoid a potentially fatal outcome. Beyond the AB system, novel feline erythrocyte antigens. For many years, the AB system was considered the full extent of feline blood typing complexity. However, cases of transfusion reactions occurring despite a successful AB match prompted researchers to investigate the presence of non-AB blood group systems. The first recognized non-AB antigen was the MYC antigen. This discovery was triggered by a hemolytic transfusion reaction in a MYC-negative cat that had received MYC-positive, but otherwise AB-matched, blood. This showed that naturally occurring alloantibodies outside the AB system could cause clinically significant acute hemolytic reactions, even in transfusion-naive type of cats. More recently, scientists have identified and characterized 5 novel feline erythrocyte antigens, labeled feline erythrocyte antigen 1 through 5, based on the presence of naturally occurring alloantibodies. Research indicates that feline erythrocyte antigen 1 is particularly immunogenic. While the clinical significance of these newly discovered non-AB antigens is still being fully determined, feline erythrocyte antigen 1 has shown the potential to induce strong naturally occurring alloantibodies that can result in acute hemolytic reactions, as documented in clinical case reports. Furthermore, cats that are feline erythrocyte antigen 1 negative and transfusion naive will readily produce anti-feline erythrocyte antigen 1 alloantibodies as quickly as 5 days after receiving feline erythrocyte antigen 1 positive blood. The primary immunoglobulin class responsible for these induced anti-feline erythrocyte antigen 1 antibodies appears to be immunoglobulin M, which is known for its potent agglutinating capabilities. These findings, both the existence of the MYC antigen and the high immunogenicity of feline erythrocyte antigen 1, demonstrate unequivocally that AB typing alone is insufficient to fully ensure transfusion safety in cats, highlighting the continued importance of comprehensive compatibility testing. Blood typing methodologies for cats. Given the urgent need for rapid and accurate blood typing, several reliable commercial options exist for in-clinic use, although limitations must be understood. 1. Typing cards. These popular in-clinic kits use monoclonal antibodies lyophilized onto cards. When the patient's blood is added, if the corresponding antigen, type A or type B, is present, an agglutination reaction, clumping, occurs. While quick and simple, interpretation can be complicated by autoagglutination, spontaneous clumping of red blood cells common in certain disease states, or rouleau formation, red blood cells stacking like coins. For cats specifically, commercial cards are available to identify type A, B, and AB blood. 2. Immunochromatographic strips. This technique involves mixing red blood cells with a buffer and allowing the solution to migrate up a membrane strip containing monoclonal antibodies. A positive result is indicated by the red blood cells agglutinating with the antibodies, forming visible red lines on the membrane. This method is reported to be generally less affected by autoagglutination than the card and gel methods, making it potentially advantageous in complex cases. 3. Gel tests. These use a dextran acrylamide gel matrix impregnated with antibodies. Upon centrifugation, red blood cells containing the target antigen will clump and become trapped within the gel, a positive reaction, while compatible red blood cells will pass through to form a button at the tube's bottom. A single tube gel test is commercially available for identifying feline A, B, and AB blood. It is important to note that even with modern tools, these point-of-care tests sometimes struggle with accuracy, particularly in identifying the rarer type B and type AB cats. Therefore, for optimal safety, any non-type A result should ideally be confirmed by an external laboratory using antibody testing or genetic screening. Cross-matching, the safety net. While blood typing identifies known antigens, cross-matching is the essential laboratory procedure used to detect antibodies between the donor and recipient that blood typing kits may miss. This testing is crucial because the sensitivity of commercial typing kits is limited, especially concerning newly discovered antigens like feline erythrocyte antigen 1, MYC, and the various canine dog erythrocyte antigens. The imperative for cross-matching in cats. For cats, due to the high risk posed by naturally occurring alloantibodies, cross-matching should always be performed before transfusion, regardless of prior transfusion history. Although some sources suggest that the evidence supporting cross-matching prior to the very first transfusion is weak, the discovery of potent natural alloantibodies against non-AB antigens, like MYC and feline erythrocyte antigen 1, strongly supports incorporating cross-matching to mitigate these unpredictable risks. Furthermore, once a cat has received a transfusion, the subsequent risk rises significantly. The immune system can become rapidly sensitized to foreign red blood cell antigens, leading to alloantibody production in as little as 2 to 5 days. Therefore, cross-matching is strongly recommended if a cat has received a transfusion 2 or more days prior, even if the original transfusion was compatible. The major and minor cross-match. Compatibility testing consists of 2 main components. 1. Major cross-match. This detects the patient's, recipient, antibodies against the donor's red blood cells. This is the most critical test, as recipient antibodies destroying donor cells cause the most severe acute hemolytic transfusion reactions. 2. Minor cross-match. This detects donor antibodies against the patient's recipient red blood cells. Cross-matching techniques. The traditional, gold standard, technique remains the standard tube procedure, usually performed in specialty laboratories. This labor-intensive method involves separating red blood cells and plasma, serum, washing the red blood cells repeatedly with saline to remove interfering proteins or autoantibodies, mixing the required components, donor red blood cells with recipient plasma for the major cross-match, for example, incubating the mixture, ideally at body temperature of 37 degrees Celsius, centrifuging, and finally examining the product both macroscopically and microscopically for signs of agglutination, clumping, or hemolysis, cell destruction. A positive finding of agglutination or hemolysis indicates an incompatible crossmatch. A key step, especially in cats, is differentiating true agglutination from rouleau formation, a benign stacking of red blood cells common in feline blood, which disperses when diluted with saline. In urgent situations, practitioners often turn to rapid point-of-care kits. These include gel tube assays. These kits use a gel matrix to trap agglutinated cells. While easy to use, studies have shown moderate agreement with the reference tube method, and they may sometimes fail to detect weakly incompatible reactions that the tube method catches microscopically. Immunochromatographic strip crossmatch. These rapid tests wick components up a strip containing antiglobulin, aiming to detect immunoglobulin coating of red blood cells. An advantage of this method in dogs is its utility even when the patient is autoagglutinating, as occurs in immune-mediated hemolytic anemia, but studies comparing its accuracy to the gold standard tube method often show a lack of sensitivity for detecting certain incompatibilities, complicating their routine use. In essence, while quick methods are available, the need for standardization and increased sensitivity highlights the ongoing complexity in selecting a reliable compatibility test in a critical setting. Feline donor management. Ethical and practical considerations. Acquiring feline blood products is inherently challenging due to the species' small size and the necessity of collection from the jugular vein. Unlike dogs, cats rarely tolerate this procedure without assistance, necessitating chemical restraint. Donor criteria and chemical restraint. Ideal feline donors are generally between 1 and 8 years old, possess a lean body weight exceeding 4.5 kilograms, and have a calm temperament. Given the risk of stress and potential injury, sedation or general anesthesia is routinely favored for blood collection in cats to ensure a comfortable experience for the donor and trauma-free collection from the jugular vein. Protocols generally aim for short duration and smooth recovery. Drugs to be avoided include alpha-2 adrenergic receptor agonists, xylazine, medetomidine, or dexmedetomidine, due to adverse effects like bradycardia and peripheral vasoconstriction, which can complicate blood collection. Blood collection systems. Open versus closed. Feline blood can be collected using either an open or a closed system, a distinction related to sterility and storage duration. Open systems involve drawing blood directly into syringes prefilled with anticoagulant. This system inherently carries a higher risk of bacterial contamination because of the multiple manipulations involved. Consequently, blood collected via an open system must be administered immediately, ideally within 4 hours, or within 24 hours if refrigerated. Closed systems utilize specialized, prepackaged bags and tubing, minimizing the exposure of the blood to external air. This method significantly reduces the risk of contamination, allowing the blood to be stored for up to 35 days if properly handled. Although closed systems represent the gold standard for reducing contamination risk, they require specialized equipment and careful execution, as studies show that contamination can still occur regardless of the system used if aseptic technique fails. Xenotransfusion, the last resort. The extreme difficulty in obtaining species-specific, compatible feline blood sometimes leads clinicians to consider the high-risk alternative known as xenotransfusion. The administration of blood from a dog to a cat. This practice should only be used as a single, one-off emergency transfusion when compatible feline blood is absolutely unavailable. While a cat may tolerate the initial transfusion of canine-packed red blood cells or whole blood with only minor reactions, the recipient cat's immune system quickly recognizes the canine red blood cells as foreign. Antibodies against the donor canine red blood cells are consistently detected within 4 to 7 days, leading to rapid destruction of the transfused red blood cells, often within a median of 2 days post-transfusion. Crucially, any subsequent attempt at a second xenotransfusion after this sensitization period, generally greater than 4 to 6 days later, risks a severe, potentially fatal anaphylactic reaction. Owners must be fully informed and consent documented, and the medical record must be flagged prominently to prevent a fatal second exposure. Transfusion reactions, diagnosis, monitoring, and management. Transfusion reactions are defined based on their etiology and timeframe by the Transfusion Reaction Small Animal Consensus Statement Guidelines, providing a standardized framework for recognition and reporting. Reactions can be categorized as acute, within 24 hours, or delayed, beyond 24 hours. 1. Acute reactions focus on feline incidents. A recent large prospective study using the standardized transfusion reaction small animal consensus statement definitions found the overall acute transfusion reaction incidence in cats receiving red blood cell containing products was 7.8%. The incidence for plasma products was much lower, at 1.1%. Febrile non-hemolytic transfusion reactions, FNHTR, definition and incidence. This is the most commonly reported transfusion reaction in cats. 5.7% incidence in red blood cell products. A febrile non-hemolytic transfusion reaction is defined as an acute rise in body temperature, greater than 39.2 degrees Celsius and a simultaneous increase of more than 1 degree Celsius from pre-transfusion baseline, for which other, more serious causes of fever, like acute hemolytic reactions or sepsis, have been ruled out. Risk factors in cats. An increased risk of febrile non-hemolytic transfusion reactions was specifically associated with increasing red blood cell unit age and administering the red blood cells using an infusion pump rather than a syringe driver. Management. While serious causes of fever must be ruled out immediately, febrile non-hemolytic transfusion reactions are generally benign and self-limiting. Management typically involves stopping the transfusion, confirming hemodynamic stability, and potentially restarting the transfusion at the same or a slower rate. Routine use of antipyretics to prevent or treat febrile non-hemolytic transfusion reactions is not supported by strong evidence and is generally not recommended, especially since acetaminophen is strictly contraindicated in cats due to severe hepatotoxicity risks. Acute hemolytic transfusion reactions, AHTR, definition and incidence. These are acute, often immunologic reactions occurring within 24 hours due to the rapid destruction of transfused red blood cells, most commonly caused by blood type incompatibility, such as a type B cat receiving type A blood. The incidence in the recent feline cohort was low, at 0.6%. Clinical signs and diagnosis. Signs include acute fever, tachycardia, hypotension, inadequate increase in packed cell volume, and laboratory evidence of hemolysis, such as red discoloration of the serum, hemoglobinemia, or urine, hemoglobinuria. Management. The transfusion must be stopped immediately. If signs of shock or collapse are present, resuscitation with crystalloid fluids and the administration of epinephrine may be necessary. Further blood should not be administered, and full investigation into the incompatibility, cross-matching, retyping, should ensue. Respiratory reactions, transfusion-associated circulatory overload versus transfusion-related acute lung injury. Acute respiratory distress occurring during or shortly after transfusion is critical and requires rapid differentiation between two main causes. Transfusion-associated circulatory overload and transfusion-related acute lung injury. Transfusion-associated circulatory overload, TACO. This is a non-immunologic reaction resulting from volume expansion leading to hydrostatic pulmonary edema, usually occurring within 6 hours. In cats, the recent study found an incidence of 0.8%. Transfusion-associated circulatory overload is suggested by clinical signs such as worsening respiratory distress, and is often associated with existing cardiac disease or rapid administration of large volumes. Transfusion-related acute lung injury, TRALI. This is an immunologic reaction caused by antigen-antibody interactions in the lungs, leading to non-cardiogenic pulmonary edema. It typically presents with acute hypoxemia, often within 6 hours of the transfusion. Differentiating treatment is key. The distinction between these two is critical because transfusion-associated circulatory overload often responds positively to judicious diuretic therapy, such as furosemide. Conversely, transfusion-related acute lung injury does not respond to diuretics, and furosemide administration should be avoided as it risks worsening the patient's condition due to volume depletion. Diagnostic tools include thoracic radiographs and echocardiography to look for evidence of volume overload. Measuring natriuretic biomarkers, specifically N-terminal pro-brain natriuretic peptide, may also suggest transfusion-associated circulatory overload in cats presenting with acute respiratory signs. If transfusion-related acute lung injury is suspected and mechanical ventilation is needed, lung protective strategies with low tidal volumes should be implemented. Allergic transfusion reactions. Definition and incidence. These are acute, immunoglobulin-mediated, type 1 hypersensitivity responses occurring within 4 hours. In cats, the incidence was 0.8% in the recent study. Feline allergic reactions characteristically involve respiratory signs, upper airway edema or bronchoconstriction, or gastrointestinal signs, vomiting, diarrhea, although facial swelling has also been documented. Management. Mild cutaneous reactions, like hives, may respond to slowing the transfusion rate and administering an antihistamine. However, severe anaphylactic reactions require immediate cessation of the transfusion and aggressive treatment involving epinephrine, often given as a continuous rate infusion, to counteract hypotension and airway distress. Corticosteroids are generally discouraged due to a lack of evidence supporting their efficacy in acute transfusion reactions. Citrate toxicity, hypocalcemia. Citrate is used as the anticoagulant in stored blood products. When a patient receives a massive transfusion, defined as replacing half the patient's estimated blood volume in 3 hours or a full blood volume replacement in 24 hours, the massive load of citrate can overwhelm the liver's metabolic capacity, leading to ionized hypocalcemia. This complication, known as citrate toxicity, can cause clinical signs such as vomiting, nausea, tremors, and electrocardiogram changes. Monitoring ionized calcium levels regularly is suggested for cats and dogs receiving massive transfusions. Calcium supplementation should be strongly considered if the ionized calcium level is less than 0.9 millimoles per liter, even if clinical signs are absent. 2. Delayed reactions. Delayed transfusion reactions occur more than 24 hours after the transfusion concludes. Delayed hemolytic transfusion reactions, DHTR. These reactions occur between 24 hours and 28 days post-transfusion. Immunologic delayed hemolytic transfusion reactions are typically caused by a secondary immune response to a foreign red blood cell antigen that the recipient encountered during the transfusion. Clinically, this manifests as an unexplained drop in packed cell volume, often accompanied by icterus or fever, as the red blood cells are gradually destroyed. This reaction type is classically seen in cats following canine xenotransfusion, where the feline body destroys the foreign canine red blood cells within days. Delayed serologic transfusion reactions, DSTR. This is an immunologic reaction characterized by the development of new, clinically significant alloantibodies against the transfused product within 24 hours to 28 days, but without evidence of overt hemolysis. This essentially means the patient has become sensitized or alloimmunized, raising the risk of a severe acute hemolytic transfusion reaction upon any future incompatible transfusion. Serial cross-matching is one way to detect this alloimmunization in previously transfused patients. Summary of best practices in feline transfusion. The sources mandate a highly vigilant approach to feline transfusion due to the unique risks associated with the species' immunology. 1. Mandatory blood typing. Every cat must be typed for the AB system before transfusion, regardless of history, to prevent immediate fatal acute hemolytic reactions, especially in type B recipients. 2. Compatibility testing. Cross-matching should be performed alongside blood typing prior to the first transfusion, and is strongly recommended prior to any subsequent transfusion after 2 days, due to the rapid risk of alloimmunization, particularly against non-AB antigens like feline erythrocyte antigen 1. 3. Donor selection. Donors must be screened rigorously for health, appropriate weight, and freedom from transmissible infectious agents. Sedation is generally necessary for comfortable, aseptic collection via the jugular vein. 4. Administration. Red blood cells should be administered through a dedicated line using an appropriate microaggregate filter. Syringe drivers are suggested over infusion pumps in cats to minimize the risk of febrile non-hemolytic transfusion reactions and potential red blood cell damage. 5. Monitoring. Close, continuous monitoring, particularly during the first 15 to 30 minutes, is essential for early detection of acute reactions. 6. Xenotransfusion. Canine blood products are a last resort, single-use option only, followed by prompt investigation and aggressive management of the patient's underlying condition, recognizing that the transfused red blood cells will be rapidly destroyed. By adhering to these comprehensive guidelines, veterinary professionals can maximize the life-saving potential of blood products while minimizing the inherent risks for both their canine and, especially, their delicate feline patients. The continued discovery of new antigens, like feline erythrocyte antigen 1, underscores the reality that transfusion medicine is a dynamic field where vigilance and continuous re-evaluation are key to ensuring the safety of every patient. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.